let's go back to the case for this patient. Greg, do you want to talk about just some of the mutational analysis that we're seeing post-TKI, the resistance, the T790M presence, and should we be testing for this after osimertinib? Is this something that you're doing at Rutgers?
So yeah, so I think in generally what we've seen, we haven't been seeing a lot of the first line use of osimertinib. So it's only typically we've only seen it with when a secondary T790M mutation has been detected, and so and then we see these tertiary mutations, the C797S, and then I think other cysteine mutations that we're actually trying to further characterize a little bit. And I think actually our experience, because maybe we're not, or we haven't seen the osimertinib first line, is that these patients oftentimes they lose the T790M when they're treated with osimertinib, and then potentially these patients, maybe not like a first line EGFR, but something like a afatinib or something like that they're treated on and potentially treated on successfully again. I don't know what the experience is where you guys are, but we haven't seen a lot of the first line, I guess, osimertinib. So it might be a little bit different mutation spectrum.
Clearly osimertinib has redefined what we do frontline. This drug, again, wonderful T790M directed therapy in the resistance setting. We move it up front. We compare it to first generation TKI. It outperforms. We're starting to see an overall survival trend. We'll know if that's real or not soon. Are we routinely testing for mechanisms of resistance post-osimertinib, or is this something that we should be recommending to community oncologists? I mean, is that, before we talk about mechanisms of resistance, the relevance of C797S, is that something that you're doing at MD Anderson?
Well, we certainly do, because we have clinical trials that target some of these mechanisms. For insertion 20 mutations, we have Post-Osimertinib. The HER2 mutants, exon 20, we can give them Post-Osimertinib, and there's also an Ariad drug as well. So we actually do that. Now, out in the community, I do recommend it, but it's not necessarily going to determine what that patient's going to receive second line.
Yeah. Paul?
That's an important point. In the era of first line, first generation TKI, it was easy to recommend a biopsy at progression because it mattered, right, in terms of finding T790M. We don't have that right now. And so, while we encourage it, it doesn't really make too much of a practical difference overall, outside of probably some small select cases. But that, the onus is on us, I think, is in the academic community to do the testing, to find those things, to be able to have the clinical ramifications to be able to provide, for the community. Yeah.
Is there an opportunity for plasma here? I mean, is this?
Oh, I do plasma always.
I mean, is it, if you're going to do some sort of interrogation about mechanism of resistance, it always starts with plasma first?
I always do. In the first generation EGFR TKIs, we got in the habit because a lot of times they would fail in the brain. Yeah. And we weren't able to access tissue. With osimertinib, we're seeing less CNS failure. Yeah. And so we've been in the habit of doing that.
Are we using what we find on routinely, what we're finding on these studies, these interrogation via plasma or tissue? Is C797S make a difference in what we do? We've had some data that maybe they'll respond to a first generation TKI. It may have to do with its location or relevance to T790M. Is this something that's truly routinely actionable in clinical practice? Is there a message to the community? If you see this, go ahead and continue the osimertinib and add back a first generation TKI, or just switch to a first generation TKI?
I think it's hard to make the recommendation outside of some consolidated set of data, and we don't have the consolidated set of data. And I guess again, the onus is on us to try to generate that. I can tell you, at our center, even between or amongst the oncologists, there's a different threshold for utilizing those results versus going forward with whatever the standard therapy might be.
I confess I've done it.
Okay.
So
you've used it to make a decision. You've put them on a erlotinib.
I have continued osimertinib with erlotinib on 2 patients.
Okay.
And one of them had a reestablishment of sensitivity and control of disease. The other one progressed.
Okay.
And I have
So-
very few qualms about doing that. I have a case where MET amplification was the resistance mechanism, so I added crizotinib to osimertinib.
Yeah, we've
as
done
has
that.
been, right?
Yeah,
And,
we've
you
done
know,
this a few
and it's
times.
worked.
Yeah.
And so I think, again, within reason, it's reasonable to try. The question is when, and you know, as it relates to, for example, Empower 150, how do we sort that temporally for the patient?